نستمر في محاضرة preprosthetic surgery. وصلنا alveolar ridge preservation. How we preserve the alveolar ridge. An important aspect of preprosthetic surgery can actually be accomplished at the time of the tooth extraction by attempting to maintain and region as much as possible. If a tooth of demand non-restaurable and planned for extraction, simultaneous preservation of the socket using a variety of bone material can aid in the maintenance of alveolar ridge height and width. Several allogenic and xenogenic bone material have been used to bone architecture, limiting the morbidity, harvesting the autogeneous bone from an adjacent intraoral site. Traumatic extraction with maintenance of buccal and lingual cortical walls is essential to preservation of alveolar bone. The site is curated and irrigated after removal of the tooth, and the graft material is placed and compressed to the level of the alveolar crest. In most cases, the graft material is covered with some type of collagen material that is held in place with resorbable suture. The implant placement inside preserved the graft bone material, usually processed in 2 to 6 months. And then after put a bone graft in the implant, the complete processes must stay for 2 to 6 months. These figures that show how we put a cortical plate cover the implant in anterior teeth. The other procedure for the mandible is mandibular augmentation. Augmentation grafting added strength to an extremely deficient mandible and improve the height and contour of a variable bone for implant placement on denture-bearing area. The type of graft material. The source of graft material include autogeneous from the patient itself, allogenic bone from the other person, and alloplastic material. The first technique that used for mandibular augmentation is mandibular superborder augmentation. The superborder augmentation was bone grafted, often indicated for several conditions. This first, when severe resorption of the mandible results in inadequate height and contour. Potential risk of fracture, when the treatment plan calls for the placement of implant in area of insufficient bone height or width. And finally, neurosensory disturbance from inferior alveolar nerve dehiscence at the location of the mandible foramen, as the severe aspect of the mandible also can be corrected. The use of autogeneous corticocancellous block of iliac crest for superior border augmentation. However, as much as 70% of resorption of iliac crest bone can occur. The cortical nature of iliac crest allows rigid fixation to secure the graft to the mandible via multiple screws, minimizing graft mobility. In some cases, implant can be placed at the same time the bone graft augmentation is complete. في الحقيقة إذا وضعت bone graft after 2 to 6 months can put implant, but at the same time we can put immediately at the implant augmentation of the bone graft. This figures shows how put the upper border bone grafting in the all side of the mandible in the body and fix it by bone plate, and then we can put an implant or delay after 2 to 6 months. For the maxilla, the maxillary augmentation is indicated in certain cases a severe increase in interarch space, loss of palatal vault, interference from zygomatic petrous area, and finally absence of posterior tuberosity notching. This may be prevent construction of proper denture and augmentation be considered. The type of maxillary augmentation. First, onlay bone grafting. Maxillary onlay bone grafting indicated in primary when severe resorption of maxilla that result in absence of clinical apical ridge, and second, loss of adequate palatal vault form. Maxillary onlay grafting is usually using with autogeneous rib or corticocancellous block of iliac crest. This figure shows the use of the ribs that taken from the 11th and 12th ribs, that is if really not below the chest, above the abdomen, can take it and do it and bone graft for the maxilla, as you see in this figure. Implant can be placed at the time of grafting or delayed to allow initial healing of the graft bone. So we can put an implant and fix it by a bone graft at the time of putting the graft. The interpositional bone grafting. Maxillary interpositional bone grafting maintains the blood supply to repositioned portion of maxilla and generally result in more predictably with less extensive resorption post-operatively. So, by interposition bone graft, we maintain the blood supply to the maxilla and the graft material. The indication of the bone deficient maxilla, first, where the palatal vault is found to be adequate formed but ridge height is insufficient. Second, anterior, posterior, and transverse discrepancies between the maxilla and the mandible can also be corrected. Third, these techniques provide stable and predictable result by changing the maxillary position in the vertical, anterior, posterior, and transverse direction, and finally may eliminate the need for secondary soft tissue procedure. The disadvantage of this technique that include the need to harvest bone from iliac crest donor side, and second, possible secondary soft tissue surgery. This is by doing a Lefort 1 osteotomy. You can see in this figure, this do by as a Lefort 1 a fracture. We do a fracture to the maxilla from the nasal septum, the tip of the nasal septum within the floor of maxillary sinus, and go posteriorly and posterior to maxillary tuberosity, and go to other side and complete the fracture as Lefort 1 and put a bone graft and either autogeneous bone graft from iliac crest or rib, and then fix it by bone plate. Other topics for this pre-prosthetic surgery is the sinus lift. What means sinus lift? The extension of the maxillary sinus into a alveolar ridge may prevent placement of implant in posterior maxillary area because of insufficient bony support. A sinus lift is a bony augmentation procedure that places graft material inside the sinus and augment the bony support in the alveolar ridge. The graft material that used for the sinus lift either autogeneous cancellous bone or xenogenic bone or allogenic bone. This includes bone morphologic protein and combination of the three-part type of graft. In this figure that have the can see in the missing first molar from long period, their maxillary sinus floor gone downward within between the fifth and the seventh teeth, so we cannot have space for put implant. By Codwell operation, we can remove the part of bone and do a window, then elevate the sinus mucosa and put bone graft material as cancellous bone from the iliac crest with our corticocancellous bone and fix it beneath the mucosa of the maxillary sinus and then suture it. We can put implant directly at the time of operation or indirectly. The alveolar ridge destruction called this technique destruction osteogenesis. A destruction osteogenesis is benefit defect due to trauma that lead a loss of a huge amount of bone or congenital defect or reconstruction of bony pathological condition often create inadequate for immediate reconstruction with implant. The considerable soft tissue defect, including loss of attached gingiva or mucus, frequently occurs in the bony discrepancies. The destruction osteogenesis involves cutting and osteotomy in alveolar ridge. An appliance is then screwed directly into the bone segment. After initial latency period of 5 to 7 days, the appliance is gradually activated to separate the bony segment at approximately 1 mm per day. The gradual tension placed on the destructing bony interface procedure continues bone formation. Additionally, the adjustment tissue, including mucosa and attached gingiva, expand and adapt to this gradual tension. The destructed segment and a newly generated bone is allowed to heal for 3 to 4 months. The destruction appliance is then removed and implants are usually placed at the time of destruction removal. This figure shows the putting of destruction osteogenesis machine to increase the length of the alveolar process. Other topic in the preprosthetic surgery is the soft tissue surgery for ridge extension of the mandible. As alveolar ridge resorption, the attach of mucosa and muscle near the denture-bearing area exerts a greater influence on the retention. Soft tissue surgery performed to improve denture stability may be carried out alone or with augmentation. The primary goal of soft tissue preprosthetic surgery are first, to provide an enlarged area of fixed tissue in primary denture-bearing or implant area. Second, to improve extension in the area of denture flange by removing the dislodged effect of muscle attached in the denture-bearing or vestibular area. The transpositional flap vestibuloplasty, or called lip switch. A lingual-based flap vestibuloplasty to a mucosal flap pedicled from the alveolar ridge is elevated from the underlying tissue and sutured to the vestibule. The inner portion of the lip is allowed to heal by secondary epithelialization. The modification by transposing a lingual-based bed mucosal flap and labially-based periosteum flap. When adequate mandibular height exceeds, this procedure increases the anterior vestibular area. This figure shows how we can remove from the labial mucosa and fix it in the alveolar ridge and leave the labial mucosa by secondary epithelialization. The primary indication of this adequate anterior mandibular height at least 50 mm, inadequate facial vestibular depth from the mucosal and muscular attached in the anterior mandible, and finally the presence of inadequate vestibular depth on lingual aspect. The disadvantages include unpredictability of amount replaced by vestibular depth, scarring in the depth of vestibule, and finally problem with adaptation of peripheral flange area of the denture to the depth of the vestibule. And we have other technique that called vestibule and floor of mouth extension procedures. The mylohyoid muscle is detached from the mylohyoid ridge area and repositioning them entirely effectively deepening the floor mouth. This procedure with labial extension procedure to provide maximal vestibular extension to buccal and lingual aspect. The technique for extension of labial vestibule is modification of labially pedicled supra-periosteal flap. After the two vestibular extension technique, a skin graft can be used over the area of the denoted periosteum. Soft tissue grafting with the buccal vestibuloplasty and floor of mouth procedure is indicated. When adequate alveolar ridge for a denture-bearing area is lost, but at least 50 mm of mandibular bone height remain. Industrial implanter generally a much more suitable treatment, and therefore vestibuloplasty with grafting is not commonly performed. This figure shows how you can do the increase in depth of the vestibule in buccal and lingual side, and by removing the attached of mylohyoid ridge and go downward within the base of the mandible, and then do a skin graft or any graft that have above the exposed bone. This figure, a clinical figure, shows how put a graft with implant. The advantage of early covering of the exposed periosteal bed, first, which improves patient comfort, second, allows earlier denture construction, and third, long-term vestibular extensions. The disadvantage, the need for hospitalization, donor site surgery with moderate swelling and discomfort experienced by the patient post-operatively. If the skin graft is too thick at the time of harvesting, hair follicle may not be totally degenerate, and hair growth may occasionally have been seen in isolated area of the graft. Palatal tissue offers potential advantage. We take the mucosa from the palatal side and to cover the area that exposed in the mandible. This advantages providing a firm, resilient tissue with minimal contraction of the graft area. Second, it's relatively easy to obtain at the time of surgery. And third, the limited amount of tissue and discomfort associated with donor side harvesting are primarily drawbacks. Full-thickness buccal mucosa harvested from the inner aspect of the cheek provides advantage similar to those of palatal tissue. However, the need for specialized mucosal to harvest buccal mucosa and extensive scarring after harvesting of full-thickness graft are disadvantaged, with mucus does not become keratinized and generally mobile and often result in adequate denture-bearing surface. For maxillary for maxilla, the soft tissue surgery for maxillary ridge extension. Adequate denture construction and stability can often be achieved after extensive bone loss due to large denture-bearing area of maxilla. However, excess soft tissue may be accompanied bony resorption, or soft tissue may require modification as in adjacent to previous augmentation surgery. Submucosal vestibuloplasty. This is the procedure of choice for correction of soft tissue attachment on or near the crest of alveolar ridge. The indications are particularly useful when maxillary alveolar ridge resorption has occurred but the residual bone maxilla is adequate for proper denture support. To provide adequate vestibular depth without producing an abnormal appearance of the upper lip, adequate mucosal length must be available in this area. A simple test to determine whether adequate labio-vestibular mucosa is present is performed by placing a dental mouth mirror under the upper lip and elevating the superior aspect of the vestibule to desired post-operative depth. If no inversion or shortening of the lip occur, then adequate mucosa is present to perform a proper submucosal vestibuloplasty. This figure shows how we can investigate and a clinical examination of upper lip by put the dental mirror and elevate it if you can see enough soft tissue to put in reconstruction of the soft tissue of maxilla. This figure shows the taking from the upper lip and cover the mucosa of the maxilla and deepening of the vestibule. This technique provides a predictable increase in vestibular depth and attachment of mucosa over the denture-bearing area. A properly relined denture can often be worn immediately after the surgery or after removal of the splint, and impressions for final denture relining or construction can be completed in 2 to 3 weeks after surgery. We can do relining or we can do a new complete denture. The maxillary vestibuloplasty done by Obergeiser described this procedure in 1958. We have submucosal tunnel, and this is technique done by vertical incision made in the midline of the vestibule from the crest of the ridge recede severely approximately 15 mm, and by metanozonope scissors introduced through the incision and the plant dissection done to separate mucosa from the submucous on the right and left side to create a submucosal tunnels. Other technique, maxillary vestibuloplasty with tissue grafting. When insufficient labio-vestibular mucosa exceeds the lip, shortening would result, so using mucosa pedicle from upper lip and suture at the depth of maxillary vestibular after supraperiosteal dissection. The denote periosteum over the alveolar ridge healed by secondary epithelialization. Moderate discomfort can occur in post-operative period, and longer healing time is required between 6 to 8 weeks before denture construction. The use of labial pedicle mucosal flap combined with tissue grafting over the exposed periosteum over the maxilla provide the added benefit of more rapid healing over area of previously exposed periosteum and more predictably long-term maintenance of vestibular depth. The palatal mucosal graft is another technique that take from the palate side and cover the area of the labial or buccal mucosa of maxilla. The supraperiosteal dissection done in vestibule and desired height is achieved. Two split thickness strip of mucosa take from right and left side of palate. The two grafts are then placed on the recipient side and sutured followed by stent placement. The palatal graft vestibuloplasty and maxillary arch. The palatal graft are used when only limited amount of graft material are needed. The donor side need about 1 month for complete healing. This figure shows the palatal graft to cover the area that have for buccal and labial side and put an implant at the time of grafting. Final topic within the preprosthetic surgery is the correction of abnormal relationship by segmental alveolar surgery in partially edentulous patient. If patient have partially edentulous, that loss of the teeth and there are not enough space for put implant or any prosthesis, we do segmental alveolar surgery. So by do two incision. The first one is vertical and split the bone, and the second one horizontal, and then do osteotomy, and then movement of the segment for any direction that can use. Thank you for listening to this lecture.